Welcome to this deep dive. We're absolutely thrilled to have you joining us today because we are tackling a premise that really fundamentally challenges how we think about our own biology.
It definitely does. It's a massive shift.
Right. And we have this fascinating document in front of us today, essentially a thought experiment. And the mission of our deep dive today is to explore this mind-bending question it poses, which is, why is there no reset button for the human body?
Which sounds so simple when you first hear it.
It does.
Yeah.
But seriously, think about that for a second. I mean, we don't hesitate to reboot our servers, our routers, or our complex software systems when they get bogged down with junk data. But when it comes to our own physical forms, we just sort of ride out the wear and tear until something inevitably breaks.
Yeah, just wait for the crash.
Exactly. So our goal today is to look at a radical proposal from this text that reimagines medical intervention from the ground up, moving away from reactive crisis management and into proactive systemic reconditioning.
It really is a profound starting point. And to fully grasp where this framework is taking us, we first have to establish the baseline concept it outlines regarding how natural systems actually operate.
The biological baseline.
Right. If you look at nature, most systems have what you would call a preferred condition. This is an optimal zone bounded by tolerable limits. Across all of nature, physical structures naturally tend to minimize internal stress, and they constantly try to balance their coupling to external gradients.
They want to stay in balance.
Exactly. And humans, of course, are no exception to this universal thermodynamic dynamic. Our bodies are incredibly capable, naturally regenerative systems. I mean, throughout your lifetime, your biology is continuously replacing cells, it's remodeling tissue, adapting to load.
Doing all that background work.
Yes. If you sustain damage to a healthy body, it usually repairs that damage immediately, or it isolates and expels the affected area to protect the whole. That is the biological baseline we are working from.
Right. Our bodies are naturally doing this maintenance work all the time, mostly without us even noticing. But what struck me reading through this is the major shift in perspective regarding how we usually think about health and sickness when that baseline actually fails.
The way we frame illness.
Yeah. Typically, when we get sick, we frame that illness as something that just happens to us. We view it as an outside invasion, like a virus we caught, or some spontaneous internal malfunction where a part just gave out.
Like a machine breaking down from the inside.
Right. We wait for things to go wrong, and then we go to war inside the body. We send in the troops. But this deep dive is going to explore a completely different paradigm. What if we rethought medical intervention from first principles? Instead of fighting the battle inside the biological landscape, what if we moved a significant category of treatment entirely outside the body?
It's a radical pivot from the norm. It really challenges the very foundation of modern medical methodology, which tends to view the patient as a closed system until a catastrophic failure forces a breach.
Okay, let's unpack this. Because to appreciate this new idea, we really have to look closely at the problem with the current paradigm.
The experimental container.
Exactly. The author makes a compelling point that modern medicine, while undeniably brilliant and highly skilled, essentially treats the biological body as an experimental container. When something goes wrong, the immediate default response is to intervene inside that container.
With pharmaceuticals, implants.
Right, we rely heavily on a massive range of pharmaceuticals, we use physical implants, and we perform a wide series of invasive surgical procedures. And while the framework is very clear that these techniques are often absolutely necessary for acute crises, they are not without significant risk.
They carry inherent risks, definitely.
Every single time you introduce a synthetic drug or cut into tissue, you are introducing new vectors of risk to that experimental container. You are creating physiological stress to cure a physiological stress.
And that's exactly where this proposal seeks inspiration for a gentler alternative. It points to a really interesting real-world precedent to anchor this idea, which is the German tradition of a cure.
I was fascinated by this part.
It's quite unique. For those who might not be familiar with European medical traditions, Germany has a long-standing state-supported system where doctors can actually prescribe a period of time, sometimes weeks, in a specific facility or environment that promotes profound rest and rehabilitation.
Like a medical retreat.
Basically, yeah. The cure is offered primarily as a preventative measure, not a last resort. It's about physically and psychologically removing the body from its stressful, toxic daily context. The proposal we're looking at today suggests that the benefits of this traditional cure could be massively enhanced.
By adding technology to it.
Right. Imagine taking that calm, quiet, restorative environment and integrating a suite of advanced modular medical treatments right into the daily routine.
I have to admit, the idea of a doctor prescribing a mandatory retreat sounds incredible. Let's be honest, just taking someone's smartphone away, stopping the doom scrolling, and putting them in a quiet forest for 3 weeks is probably half the cure for modern ailments right there.
It wouldn't hurt.
But I think it's really important here to set some parameters for you, the listener, so we don't misrepresent the material. This proposed approach is not medical advice, and it is definitely not a catch-all panacea.
No, not at all.
We are not talking about using a relaxing rehab retreat to treat a shattered femur or severe acute trauma. That's not what this is for. It is envisioned as a gentle, systemic first response when a patient presents with initial, mild symptoms of biological drag. It's a way to step in and clear the noise before the internal systems completely break down and healthy continuity malfunctions.
What's fascinating here is the conceptual leap the author makes by using high-level systems architecture to explain how this external servicing would actually function. Let's look at process engineering and modern web platforms. Think about the complex software environments we rely on globally.
They're huge, sprawling systems.
They are, and in process engineering, complex control systems are rarely written as one massive, long, monolithic piece of code anymore. That's an outdated, fragile way to build.
Because if one thing breaks, the whole thing crashes.
Exactly. Instead, they are constructed from functional blocks or microservices. Each of those blocks is complete, rigorously tested, and functionally coherent in its own right. The overall functionality of the platform is gained by coupling these validated modules together within very well-defined interfaces.
So they snap together like Legos.
Perfect analogy. The core functions remain stable, while modular components can be added, upgraded, or completely swapped out without having to redesign the entire system from scratch.
That analogy makes perfect sense. I mean, we wouldn't expect a massive monolithic server architecture to run indefinitely without a routine restart, a cache clear, and module updates to its security protocols. Yet we expect our biological hardware to do exactly that.
We really do.
We demand our bodies run for 70, 80, 90 years without any kind of routine external systemic flush. We just keep piling on the biological debt and hope the internal monolithic structure doesn't crash.
It highlights a massive blind spot in our collective approach to human health. We isolate the variables in IT so that one localized failure doesn't crash the whole architecture. But in medicine, we treat the whole body as one giant interconnected variable.
Which means when the system gets bogged down with metabolic waste, the whole architecture suffers.
Right. We expect biology to completely defy the laws of wear and tear and system degradation that we accept as absolute undeniable truth in physics and systems engineering. No engineer expects a system to run indefinitely without external servicing.
Here's where it gets really interesting, because reading through this, my first thought was, okay, great theory, but we are decades away from having the technology to actually pull bodily fluids out, clean them, and put them back safely.
Which is a totally normal assumption.
But the text reveals that we don't even need to invent some miraculous new science fiction technology to do this. We literally possess all the necessary tools right now. The toolkit is sitting right there in front of us.
It is incredibly extensive.
It really is. We already use external circulation regularly. We have advanced filtration and dialysis. We utilize extracorporeal support, which, simply put, just means medical procedures that occur outside the body, like an ECMO machine oxygenating blood.
We do it every day.
We understand metabolic clearance. We use targeted infusions of vitamins, minerals, salts, and antiviral or antiparasitic treatments all the time. We manage hydration perfectly. We even have tools for controlled photonic or light-based and sonic interactions with deep tissue.
It is a profoundly robust toolkit, but the text is quick to point out the fatal flaw in how we currently utilize these incredible instruments. The missing link is integration.
They're completely separated.
Right now, all of these amazing tools are hopelessly structurally fragmented. They are typically administered in total isolation from one another, overseen by very narrow medical specialties operating in their own silos.
You go to one department in a hospital for dialysis. You go to a completely different clinic for specific infusions, and maybe another specialist entirely for advanced light therapy.
And this happens despite the obvious biological reality that all of these interventions are acting on the exact same internal biological environment. They're all touching the same fluid dynamics.
It's like having a team of brilliant server technicians, but they each only look at one specific line of code and refuse to talk to each other about how the network is running as a whole.
That's the perfect way to look at it.
But I have to push back here a little bit, representing the natural skepticism anyone would have. The solution proposed is to create a holistic loop where we extract vital fluids, run them through these modules, and put them back.
A coherent serial servicing architecture.
Right. As a concept, sure. But as a human being, the idea of routinely routing my blood or fluids outside my body sounds honestly terrifying. Doesn't the framework address the sheer physical risk of this? What about massive infection risks or blood clotting the second it hits the external tubing? Taking fluids out of the experimental container seems to introduce a whole new set of massive complications.
That is the exact friction point, and it's a completely valid concern. However, the proposal's counterargument is that we already manage those specific risks perfectly every single day in hospitals worldwide.
Because we're already doing dialysis and ECMO.
Exactly. We know how to prevent clotting in an external loop using specialized coatings and anticoagulants. We know how to maintain absolute sterility to prevent infection. The risk isn't in the capability of doing it safely.
The risk is in doing it reactively during a crisis.
Precisely. The framework argues that these modules are already fully validated and safe when isolated. The proposal is merely linking these already safe modules under strictly controlled, calm Kerr environments.
So no emergency room chaos.
Right. By coupling them into a coherent serial servicing architecture, we create an integrated system where vital fluids can be safely extracted, run through a series of restorative treatments, and returned as a refreshed, nourished stream.
Okay, so it's about taking emergency-level tech and repurposing it for routine, spa-like maintenance.
Yeah.
That reframes it significantly. But making that pivot-moving treatment outside the body also requires us to think about what the body is doing while it's hooked up to this loop.
The internal biological software.
Exactly. We've talked extensively about the external hardware, the fluid loop, but the proposal doesn't ignore the internal side. In fact, it demands a specific internal environment to make this external reset actually stick. And that brings us to the dietary component, which is a massive piece of this puzzle. How does your daily diet play into this grand external reset?
This is where the synergy between internal and external environments becomes critical. The text details the powerful combination of a ketogenic or keto diet alongside intermittent fasting or IF.
Okay, so keto and IF.
Now, it's important to understand why this specific metabolic state is chosen for this thought experiment. A keto diet fundamentally changes how the body fuels itself by drastically reducing carbohydrate intake. This forces the body to shift its primary energy source.
It shifts into ketosis.
Yes. It stimulates a state called ketosis, where the body stops relying on glucose and instead burns ketones. The document frames ketones as a far more efficient, natural, and cleaner burning fuel for the body's internal machinery, producing less oxidative stress and metabolic exhaust than glucose metabolism.
But shifting a population or even a single patient to that diet carries a lot of biological friction, right? It's not like flipping a switch. People experience the keto flu, they get fatigued, their bodies fight the transition because we are so culturally and biologically accustomed to burning cheap carbohydrates.
Absolutely, there is metabolic friction. The transition requires the body to upregulate different enzymes and literally change its cellular machinery to process fats instead of sugars.
It has to adapt.
But the proposal argues this friction is a necessary hurdle to achieve the optimal state for systemic repair. Because the real magic happens when you combine this ketone-fueled state with intermittent fasting. When you fast, you give your internal systems a profound break. You trigger a physiological condition called autophagy.
Autophagy is such a fascinating, almost elegant concept when you really dig into it.
It really is. During autophagy, the body essentially goes into self-cleaning mode. Because you aren't constantly feeding it and forcing it to produce digestive enzymes, the immune system and cellular repair mechanisms are no longer distracted by the massive energy draw of digestive duties.
They finally have some free time.
Exactly. The body finally has the uninterrupted time and resources to recoup and recover. It starts breaking down old, damaged cells, clearing out misfolded proteins, and recycling cellular junk.
So while the external holistic loop is filtering, clearing toxicity, and nourishing the fluids outside the body, the keto and IF protocols ensure the internal environment is actively repairing itself simultaneously.
The immune system is basically on a working vacation, focused entirely on internal healing.
It's a beautifully synchronized approach.
Hmm.
You are handling the heavy lifting of clearing systemic toxicity externally, which relieves the burden on organs like the liver and kidneys, while giving the internal machinery the exact clean fuel and the uninterrupted time it needs to rebuild.
And there's another huge advantage to processing these fluids outside the body that the text leans heavily into, a concept drawn straight from the IT and engineering world, which is observability.
Right. Observability.
Yes, it's a game changer here. When you move the servicing of vital fluids to an external loop, you gain an unprecedented level of real-time visibility into what is actually happening within those fluids. In current medicine, we draw blood, send it to a lab, and wait days for a snapshot in time.
Which is pretty slow feedback.
Very slow.
Yeah.
But by utilizing inline testing and monitoring on an external loop, medical professionals wouldn't have to guess.
The specifics mentioned in the source are incredible to think about. Imagine a scenario where doctors could instantly measure a patient's red blood cell count as the fluid physically passes through the external loop. They could look at real-time T-cell profiles.
They can see exactly what's happening.
And the document mentions monitoring complement profiles, which, for those who might need a quick refresher, is just a way of measuring a specific part of the immune system's protein activity that helps clear microbes and damaged cells. By watching these markers, doctors can instantly gauge if the treatment is working.
You are literally watching the biological data stream in real time.
Just like a systems engineer monitors the load and output of a global server network.
And that real-time observability allows you to close the feedback loop immediately. This is crucial. The document points out that if a certain modular stage of the external treatment, say, a specific light therapy or a targeted infusion, is proving ineffective or causing stress based on that inline testing, it can be paused or completely bypassed on the fly.
You just route around it?
Exactly. And because of the modular design we discussed earlier, adjusting or removing one stage doesn't compromise the entire loop system. You simply route around that block. This kind of immediate feedback-driven practice where you isolate a failing variable without crashing the system is absolutely standard procedure in complex engineering.
But not in medicine.
No, as the text notes, it is currently very weakly applied in standard medical practice, mostly because we just can't see what's happening inside the experimental container in real time.
So what does this all mean? If you're listening to this and wondering why you should care about this massive theoretical paradigm shift, why does moving medical treatment to an external fluid loop matter to your future health or the health of society at large?
If we connect this to the bigger picture, it fundamentally changes where we intercept disease. In medicine, we often talk about upstream versus downstream interventions. Currently, when someone requires permanent dialysis or heart bypass surgery or requires full-time dementia care, we are dealing with a massive downstream crisis.
The crash has already happened.
The biological system has already crashed, and we are just trying to manage the wreckage. But the document argues that by externally restoring the vitality and the signaling quality of biological fluids on a routine preventative basis, we are addressing the root causes far upstream. We are clearing the systemic congestion, the impaired metabolic clearance, and the slow buildup of toxicity decades before it manifests as a chronic disease.
And by addressing those issues upstream, the need for aggressive, invasive downstream interventions is naturally reduced. This leads to a really fascinating reframing of how we use pharmaceuticals.
It changes their role entirely.
The source is careful to clarify that this proposal doesn't seek to eliminate the role of pharmaceuticals entirely. We aren't throwing all of modern medicine away. Instead, it reframes pharmaceuticals as a highly targeted support system rather than the foundational pillar of human health.
A supportive tool, not the main crutch.
Right. If your bodily fluids are routinely cleared of cellular exhaust and your internal environment is perfectly balanced through metabolic flexibility, many of the chronic inflammatory conditions that currently demand daily pharmaceutical intervention simply may never arise in the first place.
The long-term societal implications outlined here are staggering if you follow the logic. Routine external treatments, integrated into a cure-like lifestyle approach, could logically be linked to significantly reduced health insurance costs across the board. The economic burden of chronic disease management is currently crushing global healthcare systems.
It's completely unsustainable.
If you are catching and clearing cellular waste before it causes systemic, irreversible damage, the text envisions a future where we would see a massive drop in serious medical incidences. We are talking about drastically reducing the number of patients requiring permanent dialysis, avoiding the need for invasive heart bypass surgeries, preventing strokes by keeping vascular pathways clear.
Lowering rates of dementia.
Yes, lowering the rates of neurodegenerative diseases like dementia by removing plaques and toxins, and even potentially reducing the incidence of cancer by maintaining an incredibly robust, undistracted immune system.
It really is a vision of preventative maintenance taken to its ultimate logical conclusion. We wouldn't just be surviving and managing decline, we would be actively optimizing our biological hardware.
This raises an important question, and it serves as the ultimate summary of everything we've discussed from this document. Are we ready to shift our mindset? For generations, we have viewed medicine as a battlefield, a place where we fight internal biological failures once they have already overwhelmed our natural defenses. We wait for the container to break.
We wait for the crash.
This source material challenges us to abandon that reactive, crisis-driven mindset. It asks us to adopt a philosophy of routine, external bodily maintenance, utilizing the incredible tools we already have, but deploying them in a smart, integrated, engineering-driven way.
It completely flips the script on what it means to take care of yourself. Thanks for joining us on this deep dive.